Well, thank you very much. This is the final session before the final wrap-up, and so bear with me. So you heard a lot about the longitudinal health record, about AI. So I'm here along with QP. We'll give you a little bit more of a specific use cases to demonstrate. Now, the first one I will talk to you about is around clinical quality. Now, we do a lot of healthcare. So how do people will appreciate or say that you have excellent healthcare? How do we do that? By people talking about it, by social media, by TikTok? No. There is a way to measure clinical quality, and this is where very important. And when we have the specific data points to say you deliver excellent healthcare because of a public reporting, because of very much of outcome-based data, then you can say I have excellent healthcare. So it's just a very important concept that when you are measure a clinical quality. So it sounds good, but the clinical quality to get the reporting, it is actually very expensive. So here's a report from Johns Hopkins several years ago, talked about they have 162 measures, clinical quality measures. Many of those are based on a combination of claims data, EHR data, outcome driven. Did you actually get better, right? And also, a lot of these are related to patient safety. But to do this reporting, it's expensive. It takes a long time, about 108,000 person hours per year. And it costs about $5 million a year to do these quality reporting. So it's just something that you need to anticipate. Once I have a lot of people getting care, how can I ensure there's a good quality? By the way, to do quality reporting, it's expensive. Now, from UC San Diego, they published a paper last year. Now, this is interesting. They say, well, maybe AI can help. So earlier this morning, you saw about AI helping the physicians and nurses and so on and so forth. Now, this is another important aspect of it about how AI can help with the clinical measure reporting, measurement and the reporting. So UC San Diego was able to use large language model to analyze the clinical information from the record to say that did you actually deliver good care or not. What's important to point out, they have agreement with the manual effort, 90% agreement. So it's almost as good. In addition, it even pointed out that about 10 of those cases were identified where human actually made error. So it's just important to point out that this is a very useful area where AI actually could be very helpful. Now, this is from a university. Now I want to talk about a real case that I worked on. And so this is for Bay State Health. If you are familiar with Massachusetts, you'll know that we are somewhere here in our headquarters, that's InterSystems. But there's also the western part of Massachusetts. The main health system is called the Bay State. They have 5 hospitals taking care of close to 1 million patients in the region. Now, what's important is that they asked us, they say, okay, we're struggling with clinical quality measurement. Specifically is in their accountable care organization. So earlier this morning, you heard the term payviders. This is not quite the same, but this is where the providers has strong incentives to make sure the patient gets the best care. There's a specific quality measures. In this case, there are 14 measures. Each measure is tied to 422,000 incentives every year. So combined, you'll be looking at probably $6 million at risk, right? So what they need to do is every year, they need to look at the patients, about over 300 patients. This year is about 411. That's randomly selected by the insurance company. Say, I want you to report quality measures on these patients. It's very time consuming. Here's an example about depression screening follow-up. So anytime the patient had a, let's say, depression screening score, we call PHQ-9 score, that's high, the clinician is supposed to document a follow-up plan within 24 hours. And it doesn't need to carry out that plan right away, but it needs to document it. Now, the follow-up could be a conversation, could be a patient agreeing to a specific activity, could be a prescription, could also be another test. And many of these are in the free text reports. Usually the clinical quality measure managers, chart reviewers, they are not familiar with the patient. So they had to go through the entire chart to do this. It's very time consuming. They do it every year. It's very retrospective, but they would like to be more proactive, identify those patients that requires intervention. So this is about clinical quality measurement, and it is something that's very time consuming, but is also important to making sure that you deliver high quality care. So this should matter to everybody. So here's an example. Patient agreed to follow up with a therapist from, I highlight it because it's actually a real doctor name, and so this is considered a follow-up. So the question is, can AI read this and say, oh, patient had a follow-up? So this is very different from what you saw earlier, summarization, taking down information. This is very different. So what we first had to do is to train the model. Now, this is actually quite fascinating. I have another talks about some other project. We have 4 rounds of training sets. This is a traditional AI approach, but we did use some of these Gen AI capability. I'll speak to a little bit. So first of all, the model needs to be locally run, and it cannot go to the cloud. And so at that time, they don't quite have an OpenAI enterprise account, so we use a localized the language model. Secondly, the problem that we saw is in the training set they supplied, there are about 60 patients that does not need follow-up, and 6 of those actually has follow-up as a sort of a gold standard. That's not enough. Anybody does AI, they'll be like, that's a small data set. So what we end up doing is to break down at the sentence level, which is what we call a paragraph. So in that case, we have 110 paragraphs with a follow-up, and the 834 without. So that, from the AI model development point of view, our data scientists say, oh, that's good enough, and it's hard to please. He's very hard to please. So we say, okay, now we got the data, we can build a model. So when we build a model, so you can see the number, the AUC is 0.923, but what it means to the user. The user is, okay, AUC, what does it mean for me, right? So we have to explain it. So the way we explain it is, now you look at all the paragraphs, combined is 900 or so, right? So when the prediction is false, which means that there is no follow-up information, versus the actual true, which means that there's no indeed any follow-up. So when we look at the 792 of those, it predicted correctly. The AI model predicted correctly, which means that you don't need to read them. So think about it. You do not need to read them, okay? And think about if there is a, let's say, large report, all you need to find information is very small set. The AI will tell you, you can ignore these other things. You just read this. That's good enough. That saves you a lot of time. That's all there is, So this is the key thing. You do not have to read them. And of course, this is something where we had to fine tune it, making sure it's appropriate. There's a lot of adjustment that we have to do, and so on and so forth. But the key point is building out the training set. In doing so, it takes a little bit of creative thinking, and also you need to explain this to the end user so they understand why we're doing this. Now, the second part that we did is around the user interface. So earlier, Gokun talked about design. Design is so key. It needs to be intuitive. It should be useful, right? I would like to say, well, we did a reasonable job. So in this case, here is a list of patients that has been supplied by the insurance company. We need to do chart review to determine if the patient had indeed a follow-up post a positive screening, a depression screening. So you'll see that there are 2 columns here. One is probability. Probability is the confidence score by the AI model. So we actually create a confidence score that you can sort. And so confidence score could be from, at the top, 0.08, very low confidence. It could be 0.95, very high, right? The confidence is used to describe the AI's prediction. It could be, yes, the patient had a follow-up, or the patient has no follow-up. So what the user can do, they can say, let me sort by probability. So with high confidence, I can quickly scan it. I don't need to read everything. I'll just agree, right? And make it super easy. Now, when you click on the record, we show you the note. So we highlight the sentence that we use to make that determination. So you don't have to read the whole thing. If the note is very, very long, many of them are very long, because the entire year of history that you had to go through. So it highlights it, and if you agree with the assessment, you can just say, well, the patient did not have follow-up, or patient had a follow-up, so you can make a determination very quickly here. So it's very important to have even when you have the AI model, then you also have to think about the workflow. How can we make the user, in this case, a chart review, quality measure, a data manager, to be able to go through that quickly? And so that's another from a user interface point of view. Now, I was hoping to give you update, because we actually put this in a real user environment. And but one thing we did, which I don't quite have the data points to update you today. I was trying to get the results today, but we couldn't. So the user is still going through these validations and testings and so on and so forth. So we'll get it done by the end of this month. But very important to point out is that we actually rebuilt AI model using the large language model as a way to just ask questions. It's really just to say, does the patient have PHQ-9? And for the patient has the positive score, did the patient have a follow-up? And we define these are the considered follow-up items. So we use a slightly different approach and a lot more generative AI oriented. So this is the part where we don't quite have all the results yet. And but we also, at the same time, we did implement another key component using Gen AI, is to create an AI summary. So based on the data that was found after running 2 iterations of large language model query against the patient records, we say generate a summary. The summary will say, patient had a documented PHQ-9. Yes, it exists. Was the score 17? Very high. You need to document follow-up. Was the follow-up documented? Yes. What is it? Here's the thing that was actually showing you the summary of all these all these data points, including referral to behavioral health and medication management with this particular drug, all documented. So we use the Gen AI to create an AI summary, so you do not have to read the entire chart. You can quickly scan through it. And of course, the design also has the supporting evidence as well, so you can very quickly to verify it, so on and so forth. So this is to me, it's a very important. We are taking advantage of the longitudinal health record, but we summarize that. We do the evaluation using large language model. We also summarize the findings using Gen AI to help with a clinical quality measure improvement. So that's one of the very good use case that we're working with our customers on. And that's it for my portion. Now QP will continue.